This is a question, what is the best therapy for a young patient with relapsed refractory disease? There's no one size fits all. The first thing to ask the patient physician is, did you restage the patient? Did you check if the patient has a 17p deletion or complex karyotype? Those are people with high-risk disease that would require a drug such as Ibrutinib, venetoclax, or idelalisib, or any other new agent that is not chemotherapy. If the patient received chemoimmunotherapy 6 years before, it would be reasonable to consider another round of chemotherapy if the patient so would choose. The only issue is that many of us are thinking that over time, the recurrence of use of chemotherapy can lead to clonal selection of a more aggressive clone and can make the disease a little bit more aggressive and difficult to treat. So my first response is always going to be, as an investigator, participate in a clinical trial and see if you can get a better outcome with a combination study. But if you are not able to participate in a clinical trial, you can also just take Ibrutinib as a monotherapy, and that has shown, and it's now part of the NCCN guidelines, to use it for relapsed refractory disease if the patient is able to tolerate the drug. The drug, for the most part, is very well tolerated. There are only a few select patients that I would not consider the drug. Let's say, for example, if the chemoimmunotherapy that the patient received before had led the patient to have platelet count of 5,000 or very, very low counts, I would abstain from doing that because the drug can cause bleeding events, and when you have low platelets, it would be a bad combination. The other type of patient that I may not use that drug would be if you have recurrent, hard to treat atrial fibrillation, because in about up to 10% of patients you can have atrial fibrillation recurrence, and there are other options. But overall, you have to, there's no one size fits all nowadays. You have to look with what you're willing to do for the patient. In the United States, we have venetoclax approved for 17p deletion relapsed refractory disease. But right now, the FDA is evaluating the combination of venetoclax in combination with a monoclonal antibody based on the data that we have and that we will hear at ASH. So we're hopeful that the drug will be approved for all relapsed refractory patients now very soon by the FDA, which will make it easier for our patients to get. Unfortunately, many physicians in the community still don't understand that it's a drug that can come with its own set of side effect profile, different from what we have seen with Ibrutinib or idelalisib. And it's very, very important to know that the most serious problem can be the electrolyte abnormalities causing tumor lysis syndrome. So for us, it's a message that has to be repeated because people have died if you don't follow strict guidelines of protocol. Very recently, about a week ago, one of my fellows that I trained, who is now a physician in the community, had a patient that came to the hospital and required therapy. He was in renal insufficiency, renal failure, and the community doctor called him and said he wanted him to start venetoclax, and he said, no, we have to fix the kidney disease before we start this drug. And he taught this doctor in the community about this, but I don't think the message has gotten to all physicians that don't keep up with all these new drugs, because a lot of them are coming into our armamentarium. So we have excellent drugs for relapsed refractory disease, but there's no one size fits all, like I said. There is a role for idelalisib. Idelalisib is a drug that has been had a lot of bad rep, mainly due to infection complications. But now that we know the complications, the drug still has clinical activity. You just need to monitor the patients more closely for CMV reactivation and give them prophylaxis for pneumocystis. So as long as you are aware of the toxicity profile of the drugs, you can make sure that you give your patients the best options of care when they are relapsed. So there are options, but there's no one size fits all for everyone. It depends on the comorbidities, the risks, and how they present. If they had a very short response, let's say I had a patient that I was consulted on recently who had bendamustine and rituximab, and within 6 months he relapsed. That patient absolutely needs to get a targeted agent because chemotherapy already proved to you that it doesn't work. So that chemotherapy would be a no-no. That's an ultra high-risk patient, and I would give them a targeted agent. As a matter of fact, if the targeted agent didn't respond or took only a very short, brief response, that would be a type of patient that I would seriously consider sending for allo transplant evaluation. So there's still a role for allo transplant.